I learned how to sand your decks, maybe. Wash your car, paint your house, paint your fence. I learned plenty, right?
Not everything is a sin.
Oh, I'm going home, man.
Daniel-san! Daniel-san!
What?
Come here. Show me sand the floor.
I can't move my arm, right? What are you doing? What are you... Ow! Ow, what are you doing?
Now show me sand the floor.
How did you do that?
Shut up!
Sand the floor.
Hey, stand up. Show me sand the floor. Sand the floor. Sand the floor. Big sand. Sand the floor. Sand the floor. Now show me wax on, wax off. Hey!
Wax on, wax off.
Act on, wax on, hey, wax on, act, wax off. Concentrate, look at my eye, back hand, thumb inside, wax on, act, wax off, wax on, act, wax off, act, wax on, wax off. Show me interface, up, down. Up, down, up, down. Other side, look eye, always look eye. So make the house, side. Not wrist, side. This. Show me wax on, wax off. Yeah! That! Show me the fence. That! Face! That! Show me side of the head. Yes! That! Show me stand on the floor.
Why do we train? What's the purpose of meeting together? To go over things and to learn new concepts, to learn about new techniques. And that's what that little introduction was. Hopefully Mr. Miyagi woke you up, as the Starbucks did. But you know, as clinicians, why do we have learning? First of all, it increases their effectiveness in treating and helping their patients meet their goals. Improves their knowledge base for better clinical outcomes, and allows us to explore what we do to reevaluate the purpose and effectiveness for our treatment. So I don't have any doubt that any clinician out there that is driven wants to do the best for their patient, wants the best technique, wants the best outcome, wants the best treatment, because they're driven to get the person better. And that's why people enter this field. What are some obstacles to learning? Sometimes there are preconceived ideas that are not research supported may prevent you and I from learning new things. So keep an open mind during this presentation. Try to think outside the box a little bit. I will tell you that this is scientifically founded, and it does have some research to support it. So their presentation is about ASTYM. It stands for ASTYM. Basically, it's just it's not an acronym, really. It used to be augmented soft tissue mobilization, but they had to add a Y in there because somebody else already had the acronym taken. So It basically stimulates the body's natural healing responses to help treat primarily scar tissue, tendinosis, tendinopathy, things of that nature. And this is a modified version from their student presentation. So first thing, this is their a picture from their website. And notice their slogan, tapping into the body's healing potential. The whole theory behind the system, it's not about the instruments as per se, but it's about a whole process. It's using the instruments, using stretching principles, using hydration, using different types of exercise and functional type of movements to rebuild tendons, to remodel and regenerate. So how does PT typically address scar tissue and tendonitis? And notice I use the word tendonitis because that was the old, 20 years ago, somebody would come in and say, I've got tendonitis, I've got golfer's elbow, and this is just from what I gathered talking to PTs that have been in the field longer. When it truly wasn't a tendonitis, this was a chronic condition that they had. There wasn't active inflammation. There was not noticeable swelling in the tissue. And the more biopsies, the more studies they've done, histologically, that's what they're finding and what they found over the last 20 years. But usually we do ultrasound, soft tissue mode, stretching exercise, bracing, taping, ice, all are great things to use. All are very indicated per the PT's guide to practice. So these are all things we typically do. Some other things that we do, different clinicians, joint moves also, if there's joint restrictions, things like that are appropriate. But how effective is ASTYM and massage for treating tendonitis? Just doing a little study, a little research on that topic. The strength of evidence is very poor for improving outcomes using massage or deep friction mobilization that's described by Syriacs for treating tendonitis disorders. One study looked at the effectiveness of many types of PT interventions on tendonitis, and the massage group didn't even make the final cut. They weren't even in the final results. Another study found no change in the pain or function with the use of massage in people suffering from tendonitis. So we're going to we're going to open it up. It's going to be a two-way presentation. We're going to stop and get a little feedback before we go on. What have you, as a clinician and a healthcare professional, found effective in treating tendonitis? So open that up for a second. Sir. Mulligan techniques. Definitely. I know I've seen a lot of taping techniques have helped treat tendonitis to, when they're done, prevent excessive motion or things like that. I've been around that and seen that.
Mulligan taping.
Mulligan taping. Well, I mean, there's a handbook, and it's different everywhere you go. Everybody has their niche. Eccentric loading, very, very true, proven in the research. What are some common misconceptions about the pathology of tendonitis?
There's active inflammatory cells.
Right. People automatically think there's swelling in there. Like, how long has your elbow hurt? 6 months, Look at it, it's swollen. No, look at it, it's swollen. But that's the big one that I've seen. There's a lot of misconception about. And that's kind of what this whole process of treatment is based on. So let's look at the difference. Tendonitis, tendinosis. Tendonitis, the tissue of the tendon contains a large amount of macrophages, lymphocytes, and neutrophils, which you would find in the inflammatory process, the immune response to tissue injury. Acute inflammation processes such as increases in prostaglandin release, vasodilation, increased cell membrane permeability, increased blood flow. You see that in acute tendonitis. normal to low fibroblastic activity. There's not a lot of tendon being produced, things like that. Normal parallel type 1 collagen fiber alignment, so the collagen fibers are still kind of lined where they can glide and slide and be functional. Tendinosis, the tissue of the tendon has very little to no macrophage activity, little to no presence of lymphocytes or neutrophils. Very small amount of immune response going on. It's kind of like your dead face of that tissue. Hyperplasia of fibroblasts, the fibroblasts that produce the new tendon tissue are quite numerous and larger. Irregular dense formation of type 2 collagen, that's the type of collagen that's not organized in a nice parallel way, but it's kind of just very disoriented, and it's weaker, and you have more fibroblast activity. So, tendinopathy, that's what we're starting to see in the research, that the term used for tendonitis to replace tendinitis and tendinosis. You're seeing a lot of tendinopathy. So there's a typo there, sorry about that. Should be an O after the end, but it's used to replace tendinosis, which replaced tendinitis. It's a general diagnosis. It's just basically there's something wrong with the tendon. You know, it's not real specific. So I'm sure you all have seen it, and it's out there for PTA students that are getting ready to start in the fall. You will see it. Okay, notice on this slide, this is a normal slide, histological slide of a normal healthy tendon. Notice the parallel orientation of the fibers. You don't see a lot of little black dots in there, fibroblasts. So now as we go down, you start to see, this is basically, this is a tendinosis of the extensor carpi radialis brevis tendon. And what you start to see is more of these little dots, these fibroblasts. They aggregate around the blood supply there. And as it progresses, you start to see this type of thing. This is stained here blue. And basically you're looking at a bunch of irregular tissue mashed up together. It's not very parallel. It's very irregular. So that's kind of what you're seeing there. And then as you go on down, notice the aggregation of these fibroblasts. You know, there's lots of them. They're laying down this collagen around here, but it's not really in a good pattern. It's kind of all over the place. And so we kind of see that as the condition progresses and gets worse. We see how basically the tendons change histologically. So injuries occur, we know that, right? That's what we do. We treat a lot of injuries, we treat a lot of functional problems. They can happen traumatically, cumulatively, or surgically. So in ideal circumstances, proper management and cooperative repair system, usually healing occurs, the person's back on track. You know, that's what happens to a lot of your typical young people. They sprain their ankle, they do a little bit of rehab on after it's healed, they're back on track. A lot of them don't even need it sometimes, depending on the severity of it. What happens if the circumstances aren't ideal? You have the excessive or inappropriate scarring and insufficient healing and degeneration. Capillaries there's not a good blood supply on tendons and tendinopathy, and there's basically the blood supply is not very good, and you have a lot of irregularities in the tissue. So what do you see clinically? Pain, limited range of motion, decreased strength, all those things are things that we see. Are there any things up there that you as a clinician have seen that may not be on here? Because there are definitely variations in every box. Presence of any lymphedema or anything like that. Have you ever come across maybe just something to think about, you know, because we have to, as clinicians, we got to think outside the box, don't we? We got to keep thinking. We have to try to put our brains to the test, especially as we want to be more autonomous in the future. We have to really look at those things and help each other out, so teach each other. What are your options with excessive scarring or chronic inflammation? What are some common meds you all have seen that people may have been on if they had, let's say, Achilles tendonitis, golfer tennis elbow, plantar fasciitis? You don't usually see a lot. You usually see a lot of injections, don't you? It's usually like we're going to go to Voltaren. Yep. That's a big one. Voltaren is corticosteroid injections. Check this slide out here. This is speaking of corticosteroid injections. This is a mass from a tendon that had been injected. I think it said 12 times with the corticosteroids. So this little thing formed. It was like, what they think it is like when the fibroblast develops, it can go into different types of cells, and they think it kind of messes with its development and forms kind of this little crystal. So that's probably not very comfortable in the tendon, you know. That's probably not going to help healing, is it? I mean, it may calm down the pain a little bit, but what do corticosteroids actually do? They help decrease inflammation, and those type of things are very strong. So if there's not a lot of inflammation to begin with, just saying, but non-steroidals, aggressive people, we will do aggressive soft tissue moves, very time consuming. Very tough on the clinician, and you may end up with carpal tunnel after the 4th week. So, or may not, hopefully not. Manipulation, surgical, or as far as performed by a doctor. You know, we've all had patients that they had to put to sleep that they had to, in the past, frozen shoulder, they may have to do a manipulation. It's indiscriminate, it tears the tissue, so there's always a chance of injuring the rotator cuffs or other tissue around it. So surgery, additional trauma, so that's always, you know, potential for scarring. So we looked at the slide with the nice little seashell and the tendon there. So what is the ASTYM system? It's basically a soft tissue treatment that allows the clinician to stimulate the body's own capacity for healing. It's not just manual therapy using instruments, but it's basically a process altogether. It's looked at more as a process to stimulate dysfunctional tissue, help repair. So how does it work? Instruments are used along the skin to identify and stimulate dysfunctional tissue. Basically, you do an assessment. The tools, I think, are in front of Sarah. If you all want to take a look at them and pass them down. But the largest tool shown here helps you kind of get a feel of where there might be some scar. It helps you evaluate where the scar tissue might be, irregular tissue field. That's something that comes with training, and of course the course that you have to go to, they teach you how to feel that. But there are some tissue fields that may feel like scar that are normal tissue, like the palmar aponeurosis. Feels very grindy and bumpy and cracks when you run that tool across it, but it's like that on everybody. It's just the nature of that tissue. It stimulates the reabsorption of excessive fibrosis and remodeling of degenerative tendons. So basically it helps kind of gently break up some of the fibrosis so that the body can go back into its healing phase and repair itself. Then the big thing with it that I've seen in the past by using it is the functional activities and stretching exercises afterwards to help realign the tissue. According to Wolff's Law, if you're going to loosen the tissue up to where it's going to be, you're going to break it up, you need to help guide it, put a specific stress on it to remodel it. So that stretching throughout the day, that eccentric exercise, all those things are incorporated into the system because they're research proven. And the patients are encouraged to stay in their jobs or activities as long as it's not too painful or making their condition worse. So, because those normal functional activities help kind of strengthen the tendon in the direction it needs to be strengthened. So, because that's what they're doing on an everyday basis. So here's a little video. It's not very comfortable, and just for sake of time, I'm going to skip the video there. But efforts to minimize pain should be every clinician's goal. But sometimes discomfort may occur. This is it's not a very comfortable type of treatment, but it shouldn't be painful. That's the thing, it shouldn't be. And when they first came out with this, they were teaching it that you really had to bear a lot of force. And the more studies they've done, they've seen that you only have to just get a little bit of force to stimulate the body's healing response. So the whole thing about the comfort is basically sometimes that can impede a person from getting well. We've all seen that, where they don't want any discomfort in their planning, in their therapy. They don't want any discomfort with their stretching or with their exercise, or don't want any type of discomfort. We all know by the principles of exercise that there has to be a little bit, just a little bit more than what's comfortable to them to get them to physiologically adapt. So same principle here. So what was that? That was the video that you didn't see. Basically, it was a little bit long, so it's about 3 or 4 minutes. For the sake of time, I'll take it out. But you want to get your patient to the finish line, and you want to help. You want to help them along. Sometimes it may not be as comfortable, but it does. You know, the system itself yields results in most people, and helps the person as a whole functionally. So these are the some of the Bob helps and his wife. These are two of the first two that were trained in it. The system itself was developed at Ball State by Dr. Tom Spear. He's a medical doctor. He collaborated with Purdue University in their engineering program and did studies and kind of came up with the system itself. But it provides the stimulus, delivers the stimulus with less stress to the clinician. It assesses and stimulates the entire kinetic chain. So when you treat someone, if you're treating them for lateral epicondylitis, you'll actually treat them from their hand to their shoulder and do a kind of whole chain screen on them. That way, if there's restrictions somewhere else, you'll help free up the whole chain. It also demonstrates areas of dysfunctional tissue to the patient. So the key is it's a process. It's not just these little plastic instruments. Actually, they're made out of a polymer type of substance, but plastic. But it's a process. So, who has been treated successfully? People with tendinopathies, trigger finger, square veins, lateral epicondylitis, medial, rotator cuff, biceps tendonitis, Achilles, plantar fasciitis, patellar tendonitis. In my personal experience, I found the technique to be most effective with lateral, medial, Achilles, and plantar. Some in the hand, some with the biceps. But my theory on that is that those are distal extremities, and it may really help increase the blood flow to those areas and help the healing process. Whereas, a lot of things have a difficult time, a lot of modalities we have a difficult time doing the whole chain. But post-surgical scarring helps people with joint replacements, hand surgeries, knee surgeries. Used it a lot for total knee replacements after the scar is fully closed and there's no, of course, no evidence of opening in the scar. Desensitization, I've never used it for this, but I guess it's indicated. You could use it for that. It'd be a higher level of treatment, so you want to make sure they can stand the cloth on the hand and then the other things.